Good afternoon to all viewers. Welcome to the M. Center's webinar. Today it is my great honor and privilege to welcome a longtime friend, Dr. Steve Steinhubl. He is a very accomplished clinician-scientist who has done both practice, so knows the real world, and at the same time also has contributed immensely to the world of science. So he was the founding director of the Scripps Institute on digital health, right? And then I mean, he was the founding editor-in-chief for Nature Partner Journal of Digital Medicine, which has gotten very popular. And so he has, and the same, the digital, digital health at Scripps has grown quite a bit, has had great participation in the All of Us program, and has started a digital clinical trials program. And so the various initiatives that he started have gone on to grow, take a life of their own. So it is. It will be nice to hear his current state of the science and what kind of crystal ball he has to share with us for the future.
Okay.
Over to you, Steve.
Yeah, all right. Thank you so much, Antush. That was, first of all, way too kind, and but it's a great honor. I've been a huge fan of MDOT for essentially since its founding and all the work, and have been lucky to have some interaction. So it's a pleasure to go through something that's kind of near and dear to my heart. And I'm talking about digital health technologies and addressing healthcare delivery challenges, which is a lot of the focus of the work I do now at Purdue. For my conflicts of interest, I don't think any of them are going to interact with anything I'll be talking about, but I'll show those. And I'm going to cover this in three high levels. First, looking at a very high level, all of this at a delivery challenges in healthcare. Look at novel digital tools that can be applied, and then kind of try to answer the question, so what's getting in the way of, because hopefully if I'll convince you there are a lot of problems, there are solutions out there, but we're not really applying them. So let me begin with, and just picture in your mind, when you think of healthcare delivery, what is it do you think of? And if you're like most people, what you think of is inpatient hospital care. Part of that is because that's the sexy part of medicine. Obviously, it's in all the TV shows, don't focus on outpatient management. They focus on the excitement that happens in a hospital. But in reality, when you look at the numbers, inpatient care is only a small percentage of healthcare interactions. So this is data from 2019. And this is the last available data in the pre-COVID era. There were 1 billion outpatient visits that occurred in the US in 2019. And that same year, there were 35.5 million hospitalizations. So basically about 96.5% of all healthcare interactions that occurred in 2019 were in the outpatient setting. So the vast majority of healthcare actually occurs in the outpatient setting, but from I'd say from my standpoint here in biomedical engineering at Purdue, a lot of the solutions and things we think about are focused on in hospitalized care of patients, which is not a bad thing. But I think that there needs to be a switch and a change, and partially that change is coming from because of new digital health technologies. But I'll get to that later. So in looking at these 96% of all healthcare interactions in the outpatient setting, what are the reasons for those? This is just a general breakdown. So you can see the chronic disease management, and I'll get back to this and focus on that a lot, is about 40% of all these billion outpatient visits per year. Another 20% are preventative care, so ideally preventing chronic conditions or treating that. So about 2/3 of all care is focused around that. Others are newer or maybe acute injuries and the like. So what's the manpower like in the United States to manage that? and not, maybe you shouldn't be surprised, or you might be, that we have by far the lowest number of primary care physicians per 1,000 population than any economically similar countries. You can see that relative to the highest in the Netherlands, that we have about 1/6 of the primary care physicians for the population to be able to address these chronic conditions and preventative care and things that are, I think, important to all of us. It's important not only for our health and our quality of life, but it's important from a cost effectiveness standpoint too. So these are data from the CDC that found that chronic diseases account for about 75% of aggregate healthcare spending in the United States. If we look at it specific to Medicare and Medicaid population, 96 cents for every dollar that Medicare spends is in chronic condition management, 83 cents for every dollar for Medicaid spending. And then depending on the number of chronic conditions, that spending can really add up. So you notice in this graph that for the 12% of the population that has 5 or more chronic conditions, that accounts for 41% of all healthcare spending. 3 or more accounts for more than 2/3 of healthcare spending. So having better systems to manage people with chronic conditions could presumably have a very big impact on the financial, the cost of healthcare. So how much time do individuals have to seeking care? I already said we have a low number of primary care physicians. What does that lead to in terms of interactions with the person, with their healthcare provider? These are data, a little bit aged from 2018, looking at a little bit less than 100,000 visits. And with the time, the duration of the visit reported by the physician practice, which tends to overestimate the amount of time a patient spends with the physician. So you can see on average, an average adult in the US spends about 31 minutes a year speaking to a primary care physician. That 31 minutes is spread over, on average, 1.5 visits. If you include specialist care, that adds up to about 63 minutes over a year, and average a little bit less than 3 visits. So if you want to break that 63 minutes down, that's 0.012% of all time in the year is spent interacting with the healthcare system. So if you think about it just intuitively, that's probably not enough time, especially in more complicated patients, even though clearly they're going to spend more time. You'll notice in the graph on the right that for individuals 65 and older, they spend a little more time with primary care. Instead of 31 minutes, 48 minutes on average. That's still a really small amount of time when you look at the impact of chronic condition management and prevention. Whereas in the rest of the world, there's a slight uphill trend in the amount of physician interactions that patients will have. So these are data looking at 2000 to 2015, shows that the average number in comparative countries to the US increased from 7.1 to 7.6. And with these data, it stayed relatively flat, 3.8 to 3.9 over that 15-year period. So the time spent with a physician, or the number of times spent with the physician, has stayed relatively flat, at least through 2015 from 2020. So we're not increasing the number of visits or the time of visits. We already showed that we have a very small ratio of primary care physicians to patients. The physicians who are there doing that are really suffering from increased burnout, and so that's leading to a shortage of providers. When you look at what we expect of our primary care doctors, it's not surprising. This is one study that looked at a hypothetical panel of a normal primary care physician. We'll have about 2,500 person panel, and looked at the mix of chronic and acute care and everything else in that average panel, and they concluded it would take about 27 hours per day if the primary care physician were to do everything that is recommended by the guidelines for prevention, treatment, chronic and acute care, and that is required of their panel. Another study looked at the amount of time that is spent in electronic health records, and I'll briefly get back to this later, and found that for every hour spent with the patient, there's 2 additional hours spent on electronic health record work and other desk work, and that on the average, a physician spends 1 to 2 hours of their personal time each night doing additional computer work to kind of catch up and finish writing their notes over time. So all of this kind of translates into you have a lot of responsibility in primary care physicians who are taking care of chronic conditions, which are the majority of cost and impact on quality of life for our patient populations. And we have a small number of them, and we're expecting too much of them to be able to do everything they want to do. I want to just give an example. Focusing on hypertension, because hypertension or high blood pressure is one of the most common chronic conditions in the world. This is a global map, as you can see, looking at the prevalence of high blood pressure and how that is doubled from 1990 to these data in 2019. The age standardized prevalence across the world, 32% of all adult women, 34% of all adult men have high blood pressure. And in 9 countries, greater than 50% of males have high blood pressure. 2 countries, greater than 50% of females have high blood pressure. Now, these are 2019 data. I'll show coming up just US specific data, and shows that this prevalence is increasing even more. Now, hypertension, which we've had the ability to diagnose it for now over 140 years with blood pressure cuffs, easily available in home. We have treatments that are literally less than pennies a day that are available. And globally, it still remains one of or not the greatest risk factor globally for attributable deaths. So for women, it's the highest attributable risk factor, accounts for 23% of all female deaths. For men, it's second only to tobacco, where it accounted for of 18% of all male deaths. So this is a chronic condition that has a huge impact on both morbidity and mortality. We have abilities to measure it and ways to treat it. And so to me, it's really a systems of care. I've showed global data. This is just the last global data I'll show on hypertension. This is looking at women and kind of the treatment cascade. And you'll notice when you get to the cascade that only about 23% of women who have high blood pressure actually have controlled high blood pressure. And for men, it's even worse. It's 18%. And this is global data from 2019. Now, if you look at more up-to-date data in the US, this is 2021 to 2023, notice that just under half of all American adults have high blood pressure. So 47.7%. For men, it is more than half. It's 50.8%. Oh, and these are adults over age 18. You can see that for men, women in total, the prevalence increases with increasing age. And then much like the global data, that despite the high prevalence, that only about 21% of American adults who have high blood pressure are adequately treated. And remember, this is a condition that's the #1 attributable risk factor for mortality in the world. So clearly, we can do much better. And again, there are many different examples I can give, but I wanted to focus on something that's very prevalent, very important, very treatable, yet it's a system failure that we're not doing a better job. So if you look at all of this, ignoring maybe or moving beyond just the blood pressure management. So how does our current systems of healthcare translate into outcomes? So the low number of primary care physicians and the like. And I'm going to go through this quickly. I think this is probably not new data to most. So maybe one of the highest levels of how we're doing you can look at is life expectancy. This is a graph of comparable country averages compared to the United States. You'll notice that not only is our life expectancy significantly less, but the cost shown on the x-axis here is double that. The average cost per capita of providing healthcare is twice as much as the comparable countries' average. So worse outcomes at twice the cost. and the life expectancy shows great race and ethnic disparities. This is looking at life expectancy based on race and ethnicity. I spend my summers living in Alaska and working for the Alaska Native Tribal Health Consortium. So it's especially embarrassing when you look at the Native American Alaska Native life expectancy. And so you look in 2021, the Alaskan life expectancy of 65 years was the equivalent to the U.S. global population life expectancy of 1944. And Black race is the second lowest population, a life expectancy of a population of 70.8 years. And you can see the big dip on this is not surprisingly during COVID, which was the greatest loss of life expectancy since World War II. This is from a New York Times article that was very nice. It looks at the statewide variations in life expectancy. I'm going to highlight Mississippi, which is lowest at 72 years. People might be surprised if you compared that to countries like Bangladesh is right above it, that individuals who are born in Mississippi have a lower life expectancy than in Bangladesh. Hawaii has the highest at 81 years. And you can see even that is about 5 years less than the life expectancy for other countries like Japan, Australia, and South Korea. Our U.S. average of about 77 years is just under a decade less than other countries. If you look at the association, and I'm not going to go into great stuff, but there's clearly a very strong socioeconomic association. This is looking at a heat map of life expectancy across the United States, and you look at that relative to a county level heat map of poverty in the United States, and you can notice there's a substantial overlap in that. Here are our data. This is from a Financial Times article that shows that can look specifically at socioeconomic status and outcomes in the U.S. versus England. You can see that both countries have greater life expectancy with greater income, higher income levels, and that it's at the highest income levels where the U.S. matches England. But you can see also that the U.S. is, no matter what the income level, is lower than seen in England. This is reinforced here, showing that no matter what the income, there's about a 5-year gap between U.S. outcomes and England. So it's not purely a socioeconomic distribution issue. There are other issues in the U.S. that spans essentially all incomes except at the very highest level of incomes in the U.S., where it does mimic that more of what is seen in England. Moving from life expectancy, another very important measure is maternal outcomes. You can see these data that I honestly can't remember what year, 2022, that the U.S. eclipses other countries by far in terms of maternal mortality, very similar to overall life expectancy. There's race and ethnic diversity in that. We're especially bad in Black women is shown. And not only does this show the disparities, but shows that not only do we have horrible already maternal mortality, but that it's not decreasing, that it's been increasing since 2018 to these data in 2021. And not shown here are Alaska Natives and Native Americans, but they actually have the worst maternal mortality. It's 3.5 times higher than those of non-Hispanic white women, and for Black women, it's twice as high than for non-Hispanic Blacks compared to non-Hispanic whites. And we don't anticipate things to get better. This was actually a publication from yesterday that looked at access to maternal care in the U.S., looking at hospital-based obstetric services, and we know that the availability of those services improves prenatal care and improves outcomes. They looked at investigators looked at what percentage of hospitals did not offer obstetric care in 2010. 43% of rural hospitals, 30% of urban hospitals did not provide obstetric care. Now in 2022, over the 12 years they looked at, that number has increased. Over half of rural hospitals no longer provide obstetric care, and over a third of urban hospitals no longer. So you can see the trend in the graph. And this doesn't, especially in rural hospitals where there's been a lot of closures. In fact, since 2005, 200 rural hospitals have closed. So when you look at the percentage, the actual availability of maternal care is even worse because the denominator has decreased over time. Also, and as maternal, there are less hospitals, and then the hospitals that do exist have less maternal care offerings. So that's my broad overview of, at a high level, of the gaps in current care system. I want to look at some of the novel digital health technologies. I'm going to break that down in 3 sections. First, I'm going to look at improved access. I like starting this because this is when I did my cardiology fellow training, is 1996. That was the first time we had a computer that had reached over teraflop speed of processing speed. This is ASCI Red, and it took up 2 basketball courts. The size of 2 basketball courts, weighed about over 100 tons, used the same amount of electricity to heat to power 800 homes for a month, and it cost about $110 million in today's U.S. or U.S. dollars cost. This is our 2024 iPhone 16 Pro that has a speed of 2.5 teraflops, weighs about 7 ounces, uses about 2 kilowatt hours per year at a cost of about 25% per year for energy, and costs about $1,000. So just the availability and access to computer power is remarkable when you look back just over the last 30 years of how much that has changed and what's possible. The availability has also changed, looking at it in many different ways. So back in 1996, when I was, again, a cardiology fellow, we had internet access, 1 computer for all 50 fellows that we shared, and there wasn't much of a big use for it at that time. Now, 95% of all Americans use the internet. In terms of broadband, 80% of Americans have home broadband, and 97% of Americans own a cell phone. 97%, 90% of it is a smartphone. There are still gaps, and we have to address that, even though the trends are increasing. These are data from 2019. And you can see that for broadband adoption, there is substantial race, ethnicity, socioeconomic, education, and rural and urban divides. You can see that for Hispanics, 65% have home broadband relative to 80% of whites. High school or less education, only 60% have broadband compared to college or elevated 94%. And on lower socioeconomic class and rural environments, lower broadband, but that's changing. In Indiana, there's large initiatives to increase broadband, and across Indiana, it's well over 95% now that have broadband availability. Smartphones is about the same, but not quite as bad, primarily age-based, no real difference in terms of race and ethnicity, less in high school, less in lower income, less of a divide in terms of urban versus rural. And I think that, we often talk about the digital divide, and I'll get back to that. And it is true. We have to be honest about that. But it's assumed, many people will say, well, there's this digital divide, so digital technologies can't address that. And I think that we have to change our thinking. This is just a survey from 2022 that looked at 465 insured individuals and broken down by Medicaid versus commercial insured, and addressing the idea that, people on Medicaid aren't going to use digital health technologies. They found in this survey that between in the commercial insured, slightly higher, 88% of individuals had internet access at home compared to 81% of Medicaid insured. But and that of the Medicaid insured, 100% would use their smartphone, and then decreasing percentages using, or I'm sorry, 96% would, and then but the majority using smartphones, and then a decreasing percentage of other things such as smart TVs, laptops, and the like. But looking at the use of the internet in the Medicaid population, they were asked how often they use mobile banking. And the Medicaid population had a higher percentage of using mobile banking more frequently, and similar overall rate as those with commercial insurance. which again, it's only a small study of 465, but making the point that that individuals, at least in a Medicaid population, are just as likely to use online access to technologies in order to do day-to-day things, this case banking, but possibly also healthcare. Besides smartphones and broadband and other internet access, another major change that's occurred over time is wearable sensor technologies. When I started at Scripps, this was very early, and where Fitbit was just moving away from this clip-on device that you put on your belt, and if you wanted to download the data, you had to plug it into your computer. In order to get that, then less than a decade later, you have the Fitbit Sense that measures a wide variety of physiologic and behavioral measures. And what I think is the biggest push, this is a device that we use in class here at Purdue for our students, Corsano device. You can see a lot of overlap with Fitbit. The difference is the vast majority, not all of these metrics, are FDA and CE cleared. And so continuous pulse, respiratory rate, heart rate, they have blood pressure, but not FDA cleared yet. And you look at these physiologic data, really in healthcare, the only place you can get data similar to this, continuous blood pressure, continuous respiratory rate, continuous temperature, is in an intensive care unit setting, not even in just a regular ward setting of a hospital where you might get it 4 times a day or the like, but continuous. And it's really amazing capabilities that we'll talk about we really haven't taken advantage of yet in care. There's also disparities in use of wearable sensor technologies. This is a publication that looks at data from 2019 to 2020 using the HINTS data set of 9,000 individuals. And different studies have concluded different things, but 30 to maybe at most 45% of individuals today use a smartwatch or advanced activity tracker on a daily basis. You can see these are data broken down, and overall 29% of this population regularly used a smartwatch. No difference based on sex, and no difference really based on race and ethnicity, but substantial differences based on age, significantly lower in the elderly population, significantly lower in high school educated versus college degree, and significantly lower in lower income. Now, even though this routine, the numbers organically are lower, if you're saying, okay, if we want to use wearable sensors as a solution, are individuals open to that who routinely don't own one? This was a nice survey done as part of the All of Us research program, and surveyed 1,000 patients at federally qualified health systems in the late 2020. They looked at how many people already had fitness tracker and found about 21% already routinely used a fitness tracker. And when asked if they were provided one for healthcare, they found additional 60% would happily, or said they would happily use one for healthcare. And so that left about only 20% of the population who, at least at that time, was not interested, even if offered to have a wearable sensor. So a lot of work to still do, but for 80% of the population who get their care at federally qualified health centers, could be a solution or a tool that solutions can be built around. And so in terms of these digital technologies and health equity, like I said, we often talk about the digital divide. I think we need to really change the narrative and talk about the digital bridge that our technologies allow. And a term for that others have used is tequity, where as hospitals are closing in rural settings or closing in urban environments also, that technologies and digital bridges are becoming more and more available. And we have to prepare for that as they're kind of brick and mortar facilities are going in one direction, and digital connectivity and the quality of the sensors and the capabilities are increasing. Not only we talked about smartwatches, I'm going to show this one figure because we published this in 2015, and it just shows that kind of there's sensors for everything. We were overly enthusiastic in 2015, so 10 years ago, about how it can transform the quality of clinical research and healthcare on a global scale. I still really believe that. And maybe if you'd asked me in 2015, I would hope that we're a lot further along, and I'll address a little bit of that at the end of the talk, but we're going in the right direction. So we can use, not only do we increase access with these digital technologies, but I think it's a way that we can really bring precision healthcare to individuals. We think of precision healthcare almost always focuses on genomics, but we can do so much better in phenotyping. And again, I'm not going to go into the details of that as much, but just give some examples. So when I see clinic and somebody comes in and they're not febrile and their pulse is somewhere between 60 and 100, the respiratory rate is somewhere between 12 and 18, blood pressure is okay, and things, we just treat them all the same. So that's all, we'd say, oh, that's all normal. We treat everybody as part of a normal population. But what wearable sensors allow is you to be compared to you. So you, when you're healthy, compared to you now, to see if there's any early changes. And I'll give some examples of that. I'm going to start with temperature because I like it, and because we use fever as such an important measure of illness. And I think it's interesting to note that what was defined as a fever was established in 1868 in an amazing experiment. Professor Wunderlich here, who made 1 million observations in 25,000 patients and used a foot-long thermometer that they had to hold in, patients had to hold in the axillary position for 20 minutes. That is a very committed patient population and researcher. And you can see this is the English translation from 1871. Dr. Wunderlich identified what a normal temperature was of 98.6. Also defined a fever or a probable fever as over 100.4 degrees Fahrenheit or 38 degrees Celsius. And that's still now 140 years later, what we use as a definition. And what we look for is just like when you get your temperature taken, you really said, ooh, it's, somewhere here. It's always, do you have a fever or do you don't have a fever? Not surprisingly, in reality, we all have very different temperatures. This is data, 19,000 individuals who were all part of a healthy screening program. You can see that the range of their normal temperature was about 6 degrees Fahrenheit. There were some small differences with age, but you can see, and no real differences in terms of sex. This is just a one-time snapshot, but all of our temperatures provide circadian variability. So it's not only you as an individual, but what time of day. So your temperature is going to vary based on the time of day, a little bit on the day of the week, a little difference on the weekends than weekdays. And then it changes a little bit seasonally also, where your temperature is a little bit lower in the winter, and by temperature it tends to be a little bit higher in the summer. But we lose all of that variability, and when we just take a spot check and just say, oh, we're looking at whether you have a fever or not. This is one study that looked at if we know somebody's normal temperature circadian variability, can it have a clinical impact? They're looking at 62 patients who are receiving cell therapy, either CAR T therapy or stem cells in cancer treatment, and they looked at a continuous temperature wearable sensor versus standard of care spot checks that were done every 4 to 8 hours. And you'll notice from the graph here that they found that by knowing what somebody's normal temperatures are and then looking for variability in that temperature over time, that they were able to detect 12 hours prior to the onset of a fever, and that the trajectory tended to suggested that they could determine whether that was due to cytokine release syndrome or due to potentially sepsis. That 12 hours head start can make a huge difference. In fact, I'd say a life-saving difference, often in implementing antibiotic therapy, let's say for suspected sepsis. So this is hugely important, but still something that is not routinely done in healthcare that I've seen or I'm aware of. So I use temperature as an example. This is the same thing I showed before of the natural variability. It's the same for everything. This is a study that my colleagues at Scripps did, over 92,000 individuals, looking at their average resting heart rate over an average of 320 days. And you can see that about a 60 beat per minute range of normal for an individual. So, this isn't just a spot check. This is on a day-to-day basis over 320 days. What is average temperature or average pulse rate, resting pulse rate, and not shown here, but the average for an even though there's a 60 beat per minute difference between individuals, for an individual, it rarely varied more than 3 beats per minute on a week-to-week basis. So there's, we all have our own normal heart rate, very similar in respiratory rate. These are data in 10,000 individuals over 2 weeks. And the respiratory rate is often considered the forgotten vital sign because we don't measure it very closely in healthcare, but there's a lot of data that suggests that measuring it can really improve things. And again, a 12 breath per minute range in normal in these 10,000. This is just looking at 2 different people of continuous blood pressure. This happens to be from the Corsano device that I mentioned earlier that we use here. These are 2 people who have identical average blood pressures over time, over 1 month, but you can see it's hard to tell because it's small, but the dots show where on the blood pressure cuff was measured, and then the lines show the variability. So you can see, even though the average blood pressure is the same, much greater variability in the person in the lower graph compared to the upper graph. So, a lot wearable sensors can give us much better and more refined phenotype. And then I'll give one example of just, okay, if you put all that variability together, how can you use that? These are data that or a study that we did, a combination of Purdue and a company called PhysIQ, using a patch sensor and looking at multiple vital signs before and after a vaccine, looking for an inflammatory response. So by having a baseline based on the pre-data, we created, using similarly based modeling, a digital twin, and then could carry forward this digital twin as predicted vital signs based on time of day, level of activity, posture, and things like that. And then the blue is going a post-vaccine real-time vital signs, and so you're able to look at, okay, what's the difference between the current vital signs versus what is predicted, the normal for this individual. And then you look at the sum the deviations. This is in heart rate variability, respiratory rate, and temperature. And we sum all of those up into this what we called an inflammatory digital biomarker. Again, this was in a vaccine population. So we summarize those changes over time, and these are data looking at a little bit less than 90 individuals, or about 90 individuals who got a Moderna or Pfizer mRNA COVID vaccine, and look at the inflammatory response. Moderna, which is a higher dose, you can see more people had a greater inflammatory response, mostly in the second and third dose, but there were some people who had a minimal change, physiologic change. And with Pfizer, again, less people who had a greater inflammatory response. And this is just very preliminary data. We don't know, but in looking at reported symptomatology, that reactogenicity correlated very strongly with the measured inflammatory response. And then in a very small sub-study of only 19 participants, the level of inflammation measured also significantly correlated with antibody response, and other studies have shown that. Reactogenicity. So very preliminary, but this shows, if you know what's the normal individual metric for temperature, heart rate, respiratory rate, and those, that it allows you to build these digital biomarkers that are very individualized for that person, which I think is key to more precise care of individuals. Last thing I'll talk about in digital health technologies is the AI. For improving care. I mean, nothing has, I think, changed as much in such a short period of time, especially generative AI, which I'll get to. this is a paper published in 2017 that I've always liked, because maybe I've always felt that same way, that medicine has become too complicated for the human mind, and I think this is a great kind of leaping off point in terms of, okay, what's the value of AI, and a quote from the paper: the first step towards a solution is acknowledging the profound mismatch between the human mind's ability and medicine's complexity. So using AI to augment our capabilities, and you can see that this is a PubMed looking at publications that use machine or deep learning there, and how that's just taken off exponentially. In a much shorter time frame, we've gone in large language model publications from 0 in 2022 to 2,185 in 2024, and I'm convinced over the next several years that'll take off exponentially even as much. Now, there's been a lot of work in discriminative AI. That's all the early work. This is looking at 950 FDA-approved medical devices. I think this goes to 2022, so I'm sure it's higher now. But even in this, a 50-fold increase over the last 10 years, doubling in the last 2 years. So it's becoming more and more a part of care. But the majority, maybe not surprisingly, is in this using discriminative AI is really in imaging. So the vast majority of these approvals are in radiology, second most in cardiology, and then a smattering through, and these are data through October of 2023. And I think that this is great for discriminative AI. I think what that really helps with, and this is a nice paper from 2018 that broke down, where you've got diagnostic reasoning, which is, I think, how the biggest impact that artificial intelligence can have in augmenting the physician's care, that can help, synthesize symptoms and the like, exam results, and then give you probabilities. But it really augments the provider, where the provider is focused on the management reasoning and really the human aspects of that, and shared decision making. So it's, I don't like it whenever it says AI is going to replace physicians. What I hope, I'm not confident of this, but what I hope is it's going to allow healthcare providers to do what they do, only they can do, is spend time with patients, being educators, being diagnosticians, and being supported by artificial intelligence. Now, generative AI has, like I mentioned, has exploded and really widely expands the capabilities of how large language models can augment care, not only being used by the physician, but I think also, and maybe particularly, being used by patients themselves. This is just a graph that's already old, showing the performance of large language models on the medical boards. Now, the passing score is a little bit over 60% here, and you can see that basically since December of 2022, large language models have been able to pass medical boards, and at least in that sense, and have getting at levels where very few physicians in training. And the medical boards, remember, is now it's medical school and finishing your residency and starting practice. So that's a lot of medical information it can duplicate. This just shows this is from a relatively recent, from 2024, just looking at all of the medically oriented large language models that are out there. And again, it's just expanding rapidly. In terms of helping patients and augmenting the patients themselves, there's this one example that tells a nice story of a mother who took her son over a 3-year period to 17 different doctors because of unexplained symptoms of pain, and found to have occult spina bifida. So ChatGPT was able to find the diagnosis. The mother talked to a provider and confirmed the diagnosis. So not maybe a common case, but it is it shows what's possible. That this performance has been studied. There was a study that looked at 38 complex cases that have been published in between January of 2017 to 2023. These are cases where they're presented in a journal, and then there's a poll afterwards of options of the most likely diagnosis. And so they looked at the performance of large language model versus the physician. And you can see, and they use ChatGPT-4 for this, so that ChatGPT-4 got 57% of the cases correct. Medical journals on average got 36% correct. And so GPT-4 actually outperformed 99.98% of the physician readers in their diagnostic capabilities of that. So it's a good sign of both can be a resource for patients as well as for providers. And not just in the information aspect of it when you think of patients, but also in their way they interact with patients. So there have been several studies, and you have one example of that the interaction is it can mimic that of human care providers. This is one tool that hopefully the video will work. I'll show after this development of what is called Hippocratic AI. And in the development, they looked at conversational capabilities that were evaluated by over 1,000 nurses and 130 physicians that posed as patients. You'll see by the figure that the large multimodal model, in this case, what became Hippocratic AI, performed similarly to human nurses. And in every category, but actually outperformed the human nurses in terms of patient education and motivational interviewing, and as graded by humans in a blinded way of the interactions. And other studies have shown that large language might have greater empathy and the like. So still very early, but really kind of amazing capabilities. I mentioned this is Hippocratic AI, which I think is really exciting / creepy, but I think shows what the capability is. Hopefully, I'm not going to play the whole video, but I'll start it, that hopefully you'll be able to hear.
Hi, Sarah. I'm Rachel, your AI care manager. How are you doing after your appendectomy?
I'm good. I'm glad to be home with my dog, Dennis.
It's great to hear that you're back home with Dennis. I noticed that Dr. Chang has prescribed you some antibiotics, specifically ciprofloxacin and metronidazole, due to your ruptured appendix. Were you able to get these medications?
I was. I did forget to mention to the doctor that I am a...
So I'm going to move on from that, but if you, AI, the large language model, you can see not only is a graphic chatbot, but later kind of incorporates that patient's sensor data, their EHR data, and then a font of huge, background of medical expertise. Granted, it's a display video, but if it reflects reality, it can really have a major impact on care. So I'm going to conclude with what's getting in the way? And it isn't that there's certainly enthusiasm. These are just some, the picture of the documents, 2019 from the National Health Service in England, preparing the healthcare workforce to deliver digital of future care, AMA in 2022, the future of health and a blueprint for optimizing digitally enabled care. So like large, curators of healthcare systems are very enthusiastic about it, but really, I think most of our experiences are they haven't been incorporated in care. This is one great example of just kind of highlights where I think we stand. This is a perspective from 1970 about computers in medicine. And you can see, one may hope that the computer will help free the physician to concentrate on tasks that are uniquely human. That's the promise. This is a perspective piece from March of 2023. Digital tools play a big part in making the experience of being a clinician overwhelming, and that EHRs have correlated with dramatic declines in clinicians' time at the bedside. So in this, a 50-year gap, the promise of using digital technologies, in this case computers, to what it's done today has actually been the opposite of what's expected. So the way that digital technology has been incorporated in healthcare have been more, there's obviously good of electronic health records, but in terms of caring for patients, most physicians would say it has not helped. It's just contributed to burnout. And I think that's kind of one of the problems, and I'm going to kind of tell this story as an analogy of the productivity paradox, So this dates back to the late 1800s when all factories were run by steam engines. Steam engines, in these manufacturing facilities, the further you got away from the steam engine, the less power you had. And so a lot of the manufacturing was built above, below, next to the steam engine because it needed the power to do that. So in the late 1880s, we had electric dynamo was produced, and everybody thought, woo, this will be great. It'll increase our productivity. And it turned out it had almost no impact on industrial productivity. And the reason is because the manufacturing didn't change to take advantage of the technology. The dynamo was placed in the same place. Manufacturing occurred the same way. There was a small incremental benefit. It was cheaper, cleaner, and the like, but otherwise didn't improve productivity. What really improved productivity, though, was when manufacturing changed to take advantage of the new technology. So things like assembly lines. So Henry Ford, interestingly, cigarette manufacturers were leaders of that too, where they took advantage. Okay, it said electricity is just as powerful a mile down the road as it is next to the thing. So let's change the way we manufacture things to take advantage of that technology. And that's where I think we are in healthcare. We haven't done that third step yet. We have the old steam engine aspect of the face-to-face care, and I purposely picked the picture of the physician's back to the patient while they're filling out the electronic health record. I see that as the steam engine era. We have telehealth, which I think is this tiny incremental benefit. For some patients, it's still built around an episode of care, but it really doesn't take advantage of digital technologies. It's a small convenience, and I'm not bashing telehealth. It's a good idea, but it doesn't really transform healthcare. What really can transform healthcare is taking advantage of the fact that we can remotely monitor continuously and communicate with patients continuously. So we get away from episodes of care, that we really build care around passive sensing, around taking advantage of large language models to communicate and help decipher some of the data, and that there's always kind of a healthcare team that's able to watch in the background and be able to be more proactive and get away from the episodes of care unless it's needed. The biggest challenge of that today, I'll take Uptown Sinclair's, is that it's difficult to get a man to understand something when his salary depends on his not understanding it. And I think, the way the financial incentives are in healthcare now, where financial systems get rewarded not by keeping somebody at home and healthy, but by somebody coming into their clinic, coming into the hospital and being sick. And so that's a major barrier to us. So in conclusion, there are numerous existing gaps in healthcare that I believe digital health technologies can address. I think the tools exist, but the solutions are still lacking. And then finally, I think we really need to think about developing completely new systems of care that are really engineered to reach all people, that are focused on keeping people well, and that lower the overall cost of care as possible. So I appreciate everybody listening. I apologize, I didn't leave 10 minutes for questions, but if there are questions, I'm gonna try to stop sharing and try to answer questions if I can.
I have a burning question, but I think as moderator, it's perhaps my duty to allow others to ask theirs first. Anyone? Okay, I'll proceed with my question. So, Steve, you have a unique blend of, both being on the ground to see as to what's working, what's not working, and have, your hands pretty well dipped into the tech world. So, my question is largely about the last part, which is the adoption part.
Yeah.
Is this going to be a sudden transformation, or is this like like ChatGPT was a sudden? It was like a big bang.
Yeah.
Or is it like going to be okay? We are just not going to notice it. It's going to change so gradually that it will feel like it's just continuation.
Yeah, I think it's going to be rapid and difficult. And what I think is that, so there's a group we work with in Nigeria called MDOC, and they've created a solution for chronic condition management, and they've rolled it out to people whose average weekly income is less than $20. and they've incorporated, because they have Gates Foundation grant money. They've incorporated large language models into the solution, and they're have shown, with retrospective data, they're getting the prospective data now, significant improvements in blood pressure management and diabetes control and the like. And I think that it's going to be a transformational solution that comes and offers what people want, and at a lower cost. In the U.S., I think that the people who will push that are employers, because employers are really the only group that has a financial incentive to lower healthcare costs. Right? There's good data that health insurance companies actually do better the greater the healthcare costs are, at least in terms of their stock value and how they do. So insurance companies aren't going to push for lower healthcare costs. Hospitals, frankly, are trying to increase healthcare, at least reimbursement and costs. They're building more cath labs, and they're trying to do more orthopedic procedures. So I think it's going to be solutions that come and maybe address certain things. So I think maternal care is a low-hanging area where several startups have tried to address that. I think chronic condition management is going to be key, but I think that's going to start in small populations, because there are a lot of people. There has to be also some human part of it. It can't be all digital, so it has to have the infrastructure where people can talk to or visit a human, and that's what they're doing in Nigeria. They have this MDoc program, which I really admire. They want to meet the patient where they are. So if they want to see a human, they can develop it, and so I think solutions like that. Once one gets here, I think they'll explode, and then I think there's going to be challenges, because value-based care is increasing. There's a lot of issues. Those are being driven primarily by health insurance companies that are, want to happen. And the government is the biggest payer for healthcare. The 7 of the 10 biggest lobbying firms in DC are healthcare-related firms, and healthcare is the biggest employer in the country. So the government is going to have a really hard time doing transformational changes in healthcare, because that's going to lead to a lot of really annoyed voters. So I think it's got to come from outside, and has to be shown that it can be done. And then I think employers will embrace that. And then I think once that happens, it's going to explode. That's what I'm hoping. I'm wrong. I should say 80% of my hypotheses that I end up testing are wrong, so no one should bet on what I just said, but at least that's what I'm hoping turns out.
Okay. Now, this is very helpful. At least you explain your thought process, and that helps.
But if anybody has a chance, I really, look at I can't remember if it's called My MDoc on the internet, but MDoc in Nigeria just, is a great example. And I'm sure there are others out there. That's just one we work with, and love their leadership and their vision and what they're doing. But I think it is, these disruptive solutions are going to come from areas where there's no other choice, right? That they're creating a solution that takes the place where there aren't brick and mortar, there aren't competing healthcare systems and stuff. And I think once they show success, then they can expand.